Welcome to this explainer. Today, we're taking a rigorous, university-caliber deep dive into one of the most fascinating and, frankly, dangerous neuroendocrine tumors out there, the Pheochromocytoma. Now, this isn't your standard run-of-the-mill overview. We are going to map out every precise detail of this disease. We're talking a complete, lossless transformation of the latest clinical pathology. We'll trace the journey of this tumor right from its neural ectodermal cellular origins all the way to the highly specific pharmacological sequencing you absolutely need in the operating room. So get ready for a dense, highly structured exploration of adrenal medullary physiology and pathology.
Okay, let's dive right into our syllabus. We're breaking this complex topic down into 6 logical phases: catecholamine physiology, pathology and epidemiology, clinical features, biochemical diagnosis, advanced imaging, and finally pre-operative management. Section 1, catecholamine physiology and synthesis. Let's cover the adrenal medulla basics. To truly understand pheochromocytoma, we've got to start way back at the embryonic level. Think of the adrenal gland not as one organ, but actually 2 entirely different organs mashed together. The adrenal cortex, which makes up about 80% of the gland, is a mesodermal derivative, coming from the coulombic epithelium and urogenital ridge. But the adrenal medulla, completely different story. It develops around day 45 of intrauterine life, makes up the remaining 20%, and is a neuroectodermal derivative straight from the neural crest. Because of that lineage, the medulla basically acts like a highly specialized sympathetic ganglion. It pumps out catecholamines in a strict 80-20 ratio, 80% epinephrine, 20% norepinephrine, plus just a tiny trace of dopamine. So how's it made? We start with tyrosine. Converting that to dopa via the enzyme tyrosine hydroxylase is our rate-limiting step. From dopa, we get dopamine and then norepinephrine. But here's the crucial part. That final jump to epinephrine requires an enzyme called PNMT. And PNMT is uniquely stimulated by the high local concentrations of cortisol that drain directly down from the adjacent adrenal cortex.
Now, before we leave basic physiology, we need to clear up a really widespread misconception. We know the medullary granules contain catecholamines, small ones for adrenaline, larger dense ones for noradrenaline, along with opioids and chromogranin A. But what about adrenomagellin? Well, despite the very suggestive name, it is actually not produced by the adrenal medulla. I know, right? It was simply first isolated from a patient who happened to have a pheochromocytoma. In reality, it's produced by the endothelium, it's an incredibly potent vasodilator, and there's some really exciting research looking at its potential to inhibit endothelial cell apoptosis. If that pans out, it could literally be a game changer for treating sepsis and septic shock.
All right, moving on to Section 2, pathology, genetics, and epidemiology. Let's look at the updated numbers.
Now, what's really interesting about the current evidence is that we have to completely shatter the medical dogma of the past. That classic rule of tens for pheochromocytoma you might have learned, completely obsolete. Modern epidemiological evidence reveals drastically higher numbers. Extraadrenal tumors aren't 10%, they're actually 25%. Familial cases, not 10%, but 40%. Bilateral cases, also 40%. And most alarmingly, the malignancy rate is approaching 50%, not 10. We see this immense malignant and metastatic potential, especially in tumors carrying the SDHB or succinate dehydrogenase B mutation. So if you see a young patient, say someone in their early 20s, presenting with this disease, your suspicion for a familial syndrome like MEN2, von Hippel-Lindau, or NF1 has to jump immediately to the top of your differential.
This brings us to a really critical biochemical and anatomical split. About 75% of these tumors are classic adrenal pheochromocytomas. And because they live inside the adrenal gland, where, as we just discussed, cortisol stimulates PNMT, they actively produce epinephrine. However, the other 25% found outside the adrenal gland are classified as extraadrenal paragangliomas. Because they're outside that cortisol-rich adrenal environment, PNMT is completely absent, meaning they can literally only produce norepinephrine. Around 20% of these extraadrenal tumors arise from sympathetic ganglia, meaning they're usually highly functional and they most commonly pop up in the organ of Zuckerkandl in the abdomen. The remaining 5%, they arise from parasympathetic ganglia, like the carotid body or jugular bulb, and those are mostly non-functional.
So, on a cellular level, if we take a tissue sample from one of these tumors and put it under the microscope, what are we looking for? We're looking for its defining architectural signature, the Zellballen pattern. It's this classic histological nested pattern of cells that absolutely confirms our diagnosis, especially when we use immunohistochemistry and see positive staining for neuroendocrine markers like chromogranin A, synaptophysin, NS100. Section 3, clinical features and symptomatology. Okay, so when this mass of neuroectodermal cells starts dumping unregulated pulsatile waves of catecholamines into the bloodstream, what actually happens at the bedside? Let's look at an archetypical clinical case that really highlights the danger of misdiagnosis here. Imagine a 55-year-old guy presenting in the middle of the night with profuse sweating, palpitations, and a severe episodic throbbing headache. His ECG shows sinus tachycardia, but his troponin is negative. His blood pressure during the attack is an absolutely alarming 190 over 120, but by morning, the symptoms totally resolve and his blood pressure normalizes to 110 over 70 after just 2.5 milligrams of amlodipine. The initial impression is usually a panic attack. But guys, this is a massive trap. Less than 1% of panic attacks are actually driven by a pheochromocytoma. That severe throbbing headache and that profoundly elevated systolic blood pressure, those are glaring red flags that mandate a thorough endocrine workup.
And honestly, that severe headache is not just some side note. It is the central clinical feature. Episodic headache occurs in an astounding 95% of pheochromocytoma patients, making it the single most prevalent symptom we see. This pairs up with palpitations and profuse perspiration to form the classic clinical triad. Now, interestingly, while episodic hypertension shows up in 75 to 85% of patients, up to 15% can actually have completely normal blood pressure during an episode. And contrary to popular belief, sustained endocrine hypertension is only present in about 20% of cases. Honestly, if you're seeing sustained hypertension, you should probably be thinking more about primary hyperaldosteronism or Conn syndrome.
To capture the full spectrum of these hyperadrenergic spells, we use the handy 6P plus W mnemonic. Let's run through it. Pain, often abdominal, which is actually linked to secondary hypercalcemia. Then we have palpitations, perspiration, and panic attacks, like we just discussed. Pallor is extremely important here. Why? Because these tumors can produce erythropoietin, causing a paraneoplastic polycythemia. So if you see pallor, that is a major red flag for malignancy. And finally, postural hypotension and weight loss, both driven by relentless chronic sympathetic overactivity. So the crucial point is how we actually quantify that postural hypotension, because clinically it's far more dangerous for these patients than their hypertension. Thanks to that chronic sympathetic overdrive, their intravascular volume is profoundly reduced. They are operating in a severely volume-depleted state. We measure this actively at the bedside using the 30-20-10 rule. Here's how it works. You have the patient lie supine for 10 to 15 minutes, then have them stand for 2 to 5 minutes. If their heart rate shoots up by more than 30 beats per minute, their systolic blood pressure drops by more than 20 millimeters of mercury, or their diastolic drops by more than 10, boom, you've confirmed severe volume depletion that absolutely must be addressed.
Section 4. Biochemical diagnosis and incidentalomas.
Once we suspect the disease clinically, it's time to hit the lab. First things first, the old clonidine suppression test, the one that relied on 0.3 milligrams of clonidine to suppress normal catecholamine release via alpha-2 agonism, yeah, that's completely obsolete in modern practice. Instead, we have to look downstream at the metabolites, and this brilliantly illustrates why measuring parent catecholamines directly is basically useless. Their secretion is just too highly pulsatile. Instead, we look at the breakdown products. Adrenaline is metabolized to metanephrine and VMA. Noradrenaline breaks down into normetanephrine. Dopamine breaks down into HVA. Because of this constant metabolic breakdown, our frontline screening test of choice is the 24-hour urine fractionated metanephrine and normetanephrine assay. It boasts an incredible 98% sensitivity and specificity.
However, precision requires pristine conditions. You absolutely must stop interfering drugs like tricyclic antidepressants, L-DOPA, and NSAIDs before you even think about running that 24-hour urine test. Now let's say you have a young patient where you heavily suspect a genetic syndrome, like MEN2, where 50% of patients have bilateral Pheos, or maybe VHL or NF1, which typically present unilaterally. If their urine test comes back negative, you do not stop there. For these high suspicion cohorts, you elevate straight to the plasma fractionated metanephrine test. Sure, it has slightly poorer specificity, but it guarantees 100% sensitivity, and you need that peace of mind. Sometimes, though, we don't catch these VIA symptoms at all. In fact, about 25% of these tumors are incidentalomas, found on a scan you ordered for something completely different. Now, while 95% of incidental adrenal masses are totally benign, and roughly 80% of those are endocrine inactive, we still have to rigorously rule out the active ones. Usually, that means looking for cortisol-producing lesions first, followed right behind by pheochromocytomas. If the mass is non-functioning, we look for very specific malignancy alarm signs on the CT that mandate surgical excision. We're talking a size greater than 4 centimeters, a CT density greater than 20 Hounsfield units, or a CT contrast washout of less than 40%, because malignant tumors aggressively hold on to that contrast. Oh, and a quick clinical pearl. If a patient presents with dilated cardiomyopathy, you must exclude pheochromocytoma along with sarcoidosis as an underlying endocrine cause.
Section 5. Advanced Diagnostic Imaging Strategies. All right, once we have our biochemical confirmation locked in, we have to physically locate the tumor using a very strict protocol. Step 1 is always an MRI of the abdomen, which is classically superior to CT for this specific pathology. What we're looking for is a T2 hyperintense mass, which often has visible hemorrhage or cystic changes. But what if the biochemistry is screaming positive, yet your abdominal MRI is completely clear? Well, that heavily suggests an elusive extra-adrenal paraganglioma hiding somewhere else. In that scenario, we pull out the big guns, a gallium dotatate PET scan. This advanced imaging specifically targets somatostatin receptor type 2 right on the surface of the tumor, and it is vastly superior to the older MIBG and FDG PET approaches for mapping out metastatic or extraadrenal spread. Section 6, Pre-operative Pharmacologic Management. Let's look at the rigid preparation required here. Let's move to our final phase and see how this all builds to the operating room. The definitive treatment here is a laparoscopic retroperitoneal adrenalectomy. But listen carefully. You cannot simply roll this patient straight into the OR. Doing so basically invites a fatal intraoperative hypertensive crisis. The preparation sequence is quite literally a matter of life and death. First, the patient must be admitted 10 days prior to surgery. Step 2 is aggressive fluid hydration. We're pushing 2.5 to 3 liters to reverse that severe intravascular volume contraction we diagnosed earlier. Step 3, started 7 to 10 days out, is mandatory alpha blockade. We have to stop that alpha-1-mediated vasoconstriction. Only after sufficient alpha blockade has been established, usually 2 to 3 days before surgery, do we initiate Step 4, beta blockade. We use agents like adenol, starting at 12.5 milligrams twice a day, or propranolol, strictly to control the heart rate. If you give a beta blocker before alpha blocking, you leave the alpha-1 vasoconstriction completely unopposed, precipitating a catastrophic hypertensive crisis. Never ever mix that order up. The undisputed gold standard for that critical alpha blockade is a drug called phenoxybenzamine. Because it's a non-selective, non-competitive, irreversible alpha-1 antagonist, it provides a permanent, long-lasting shield against the massive catecholamine surges the tumor is inevitably going to release when the surgeon physically manipulates it. We typically start dosing at 10 milligrams once daily and aggressively step it up to 3 times a day over that 10-day admission. Now, for board exams and alternative clinical scenarios, you should definitely know the backups. Prazosin starting at 2.5 milligrams, tiorazicin, calcium channel blockers like amlodipine, and occasionally the historical agent metatyrosine. Even with utterly perfect preparation, mechanical compression of the tumor during the actual adrenalectomy is going to release a tidal wave of catecholamines. There's no getting around it. The anesthesia team must have acute pharmacological tools drawn up and ready to push. While some older textbooks might still mention phentolamine, modern practical management relies heavily on rapid-acting IV vasodilators like sodium nitroprusside or nicardipine to immediately suppress those sudden violent blood pressure spikes. And then, following a successful removal, we verify the patient's biochemical cure using post-operative 24-hour urine fractionated metanephrines. So we've mapped this complex disease all the way from its neural crest origins right into the surgical suite. But as we reflect on the sheer physiological power of the adrenal medulla, I want to leave you with a fascinating question to chew on. Think back to adrenomedulin, that potent endothelial vasodilator we talked about earlier, first discovered in a pheochromocytoma patient. Could the very mechanisms and peptides that make this neuroendocrine tumor so uniquely deadly actually hold the exact physiological keys we need to reverse severe systemic endothelial dysfunction in lethal conditions like septic shock? The answers are still being uncovered at the bench right now. Keep analyzing, keep exploring, and I'll see you in the next explainer.